everyone. My name is Shuchi Khosla. I am one of the resident psychiatrists here at Michigan State University, and I would like to welcome you all at the Muslim mental health track of clinical care considerations. On our track today, along with the wonderful audience, we also have two esteemed panelists and my technology moderator, Farha, with us. So I'll start by introducing the first presenter, and then we will have her presentation play while I'll have her spotlighted on the video. If you have any questions or comments, please feel free to use the chat box. You can send the questions directly to the presenter. You can send them to me, or you can put them in the chat box. We will have a Q&A at the end of both presentations. Also, towards the Q&A, if we find that somebody finds a question that they haven't sent beforehand, you can always use the raise hand feature, and I can get you and you can ask the question. For the entire presentation, I would request that everyone keeps their volume off. Please feel free to request a video on if you'd like your face to be seen. We're more than happy to work this in either a video on or a video off format. So without further ado, it is my privilege and pleasure to introduce who I just found out today is one of the co-residents with me. We're in similar training at different programs. Dr. Hira Silat, she's an MD. She's a psychiatrist in training in her 4th year at Duke University School of Medicine, and her interests are different modalities of psychotherapy.
So, I am a psychiatry resident at Duke University. I am from Karachi, Pakistan, where I grew up in a Muslim household. And what I was just saying in the presentation was that when I first came to the US, I was surprised that a lot of my patients, as I'm in the South, in North Carolina, a lot of patients here are faith-based, and faith is really important in their lives. They want to talk about their faith with their providers and often feel a hesitation in talking about it. And providers feel an even greater hesitation in talking about faith-based issues with patients because we feel like we don't have adequate training. So with that experience and with my own faith background, I really started to explore trainings in the field of spirituality and mental health. And I got this really lovely training from the University of Bowling Green State University and the University of Maryland. And they and I also connected with my theology and professors in the Duke Divinity School, and have learned a lot from them. So I thought I'll share some of what I've learned and some of the cases that I've seen in my residency, and then hear from you all what your thoughts are about how we could approach this and have a discussion. Okay, so let's start with the learning objectives. I would be talking a bit about the role of religion and spirituality in psychiatric care, what normal spiritual development looks like, how the provider should approach it, what life-affirming and life-limiting forms of spirituality are, spiritual problems and psychopathology, religious beliefs and their link with psychiatric medications, and then some cases about religious themes in psychosis, in OCD, and spiritual injury and trauma-related disorders. So let's start with a case. This is a patient that I saw in my psychiatry clinic here at Duke. It's de-identified information. It was a middle-aged Muslim patient. He presented to the psychiatry clinic. He had profound depression and anxiety as well as PTSD. His therapist recommended that he should get psychiatric care for medication management because his symptoms are not controlled otherwise. The patient shared with me that he's very reluctant to take medicines. He expressed a mistrust of all healthcare providers and medications in general. was worried that he doesn't want to take anything that's addictive, or that because that something addictive could be haram, and he doesn't want to take something that will change his personality, make him more dependent, and affect his relationship with God. So I want you all to take a minute to think about how you would respond to him, whether whichever role you are in, like in the psychiatric role, or therapist role, a social worker role, or even like if you were to meet someone who had these questions in general life, what would your approach to this be? And then towards the end of my presentation, I'll come back and talk more about this case. So there are 4 key processes of spiritual development. This is a frame that actually a lot of my material is derived from spirituality-based research that is not limited to any one faith. So it's not necessarily Muslim Islamic psychology research, but this is a construct that I found very interesting. So I included it, and the way this works is that spiritual development goes through phases. We all have a phase in our life where we discover God. Even if we were born in a Muslim family, you could look back and see your relationship with God and your journey getting towards God, and how you truly begin to understand as a child who God was. And once we discover God, there is often a phase that comes, we have a construct, or we think about God a certain way, and then in almost everyone's life, there would be a phase where they would struggle. There would be a phase of struggle because they would have questions come up in their lives for what it could be anything, and that those questions would make them think about God differently. Like they would ask questions like you could ask questions like, why is there suffering in the world? Why does God do this and not this? And those questions lead to a form of spiritual struggle. Now, at this stage, a lot of people, for them, the struggle is so hard, they fall out of faith completely and never come back. And for a lot of people, the struggle leads to them rising from that struggle and transforming in a way that they are now even closer to God than they were before. So that's the stage of transformation. And the stage of conservation is when you've transformed, and all of these stages are not linear, and they're not going to happen only once in anyone's life. But once you've transformed, you have now what do you do to maintain your spiritual strength and maintain your spiritual growth and continue on this journey now that you are in a better place? So that's conservation. So that's normal spiritual development. And I want to highlight that because struggles in spiritual development are normal. So not every struggle needs to be pathologized. We would talk more about when it can become abnormal or when it can become a feeling of being stuck. And in that case, mental health help is needed. So why integrate spirituality into mental health care? There's a lot of research about this, but from a Muslim point of view, I think what a lot of Muslim patients find is that because of our faith, in our faith, Islam and Muslims, Islam is the center of our life and everything revolves around that. And we would want to do everything with God's pleasure and not want to do something that Allah Ta'ala doesn't approve of. So it can be very scary for a practicing Muslim patient to come to the psychiatry clinic if they're not very aware of mental health, because they don't want to do something that could lead them away from their faith. So it's a very genuine question that my patient was asking. So clients who are spiritual usually want healthcare sensitive to faith. So that's one reason. And then people turn to religion in order to cope with difficult situations. It has been shown to improve mental health outcomes. RS would refer to religion and spirituality for the rest of the slides. And the last point is also very important, that religion and spiritual issues can also be a source of mental health problems. And that's something that we have more trouble understanding as psychiatric providers and as mental health providers, as faith leaders, about how that could happen. So that's something that I want to address a little bit more in my slides today. So I've written here the psychiatrist orientation, but this could apply to therapists and social workers too, and any other mental health providers. What is an appropriate provider orientation? What is an inappropriate provider orientation when you're trying to provide spiritually affirming mental health care? Spiritual avoidance is a problem that most of us fall into here because a lot of psychiatrists and mental health providers feel scared of, not scared necessarily, but feel discomfort talking about spiritual problems, so they would avoid talking about it. Or they could avoid talking about it because they don't realize the importance of spirituality in a patient's life if they're not spiritual themselves. Or the fact that they don't realize that it could help with their mental health. So there is some level of spiritual avoidance that's quite common in mental health providers. Spiritual exclusivism is when you feel that your faith and your spiritual tradition is the only right one. So that sort of, and then nothing else can help a patient. So that's concerning. I hope that providers wouldn't have that attitude, but that's something to be mindful of. Spiritual over-inclusiveness is also another thing to be mindful of. A lot of us are very open to different spiritual traditions, concepts from different faith backgrounds, but it's not necessary that because you're a faith-based person and your patient is a faith-based person, that you're all under the same umbrella and the patient necessarily feels the same way too. And this is especially important to be mindful of if you are treating a patient who's from the same faith background as you are. So if you're a Muslim provider and you're treating a Muslim patient, then you have to be even more mindful of this because it's possible that their values are different from yours. It's possible that their traditions of grieving are different from yours. And you just can't assume that because you're Muslim and they're Muslim, you're all in the same umbrella. That has been the source of seeing a lot of invalidating and dismissive things by providers towards their patients. So that's something we all need to be mindful of. Helpful provider orientations goes without saying, involve empathy, respect and appreciation, and spiritual self-awareness. So that is very, psychoanalytically, if you look at it, we all, in psychoanalysis, one of the things that you're taught is you really need to know what you yourself are going through in the moment, in the patient encounter, to be able to help the patient. And spiritual self-awareness draws on the same concept, and what that means is that you know what your values are spiritually, where you are spiritually. Are you a spiritual person, not spiritual person? Is there a concern that there might be a bias that you may have towards certain spiritual backgrounds? We all have implicit biases. I don't think that it's fair. Like, if you think that you don't have any implicit bias, then that's more concerning. The important thing is to be aware of those biases so that you could work on them. So with this background, I want to talk about how spirituality can be helpful and can be used to help our patients, and how spiritual issues could be a problem that our patients are facing, and where to go from there. So I really like this term, life-affirming forms of spirituality. Life-affirming forms of spirituality, broadly speaking, are those spiritual practices, resources, values, beliefs that help a patient develop greater psychological well-being. So you would want to encourage those. You wouldn't want to discourage those. You want to know how these things are already helping a patient when they come to your care. So for instance, spiritual communications like religious services, oh, sorry, I can't see my, okay, spiritual community resources like religious services, like going to the mosque, going to the church. That's a good like way for patients to be engaged in their community. Volunteering, counseling, community meals, and functional support from your community, role models. Those are all important spiritual community resources that patients have. Spiritual practices include prayer, fasting, all the pillars that we follow, and then spending time in nature, journaling. All of these could also be important spiritual practices for patients. Charity, pilgrimage, spiritual systems of belief. So spiritual systems of belief refers to finding those things. So these are very important life-affirming forms of spirituality, because whenever your patient is going through a hard time, for instance, if you have a patient who is suffers from the loss of a family member, or they were diagnosed with a terminal illness, often spirituality or religion will help them find meaning in those life issues, and it can be very grounding and can give them a sense of purpose and motivation to go on. And then this concept of istikhara, seeking spiritual wisdom when making decisions, and other forms of like, and look, reading from the Quran and any other written set of teachings. So those are all life affirming. Spiritually based cognitions, that's my favorite slide. I think that refers to how Allah Ta'ala, like for Muslims in particular, Allah Ta'ala has taught us certain things in our faith that are so beautiful, that if those things can be very helpful to keep in mind if someone is going through a hard phase. So for instance, the hadith that says that Allah Ta'ala is how you expect him to be. So and this is a saying by Shams of Tabriz, and what he says here is how we see God is a direct reflection of how we see ourselves. If God brings to mind mostly fear and blame, it means there is too much fear and blame welled inside us. If we see God as full of love and compassion, so are we. So this is like the crux of one of the. I think it's referred to as the first rule of love in the 40 rules of love, and it points to the central tenet of Sufism, that if you want to know about God, you need to know about yourself. If you look at yourself kindly, you're more likely to be able to access the kindness that Allah Ta'ala has for us. We could talk for hours about this, but this is like how spirituality helps our patients. And then virtues and values that are not specific to one religion, one spiritual tradition, but every religion, spiritual tradition encourages love, forgiveness, mindfulness, and all of these help people go on in a difficult, if they're having mental health crisis or mental health problem. Moving on to life-limiting forms of spirituality, which is harder to understand, like I mentioned earlier. This is when spiritual issues come up that can be a source of distress to the patient. And by that, I don't mean the ordinary level of distress that comes when you have a spiritual struggle. Like I mentioned earlier in the slide, that part of normal spiritual development is to have spiritual struggles. We all go through them, and and that leads to positive transformation. This is more when you get stuck. So we'll talk about each of these individually. One of the ways you get stuck is if there is an unresolved spiritual struggle. This could be a sense of conflict with God, like why God doesn't love me, why would God do this to me? And people can get really stuck there, and it can lead to, like I said, a falling out from faith, but it can also lead to a lot of depression. Intrapersonal struggles, like a conflict or struggle with one's beliefs or practices. For example, you really want to pray 5 times a day, but you have a hard time praying 5 times a day. Then you feel guilty about that, and then you feel but you still don't pray 5 times a day, so you feel even more guilty, and that guilt makes you procrastinate even more, and then you don't do it even more. So the guilt is becoming a little bit pathological here. So that's an example of an unresolved spiritual struggle. And then interpersonal struggles, which we all know of, is when you're bullied for being of a certain faith tradition, or when you're treated differently in the community, and that could lead to a lot of mental distress too. Spiritually based over scrupulosity, I think that is important to be mindful of, that a lot of, and this is where it's really helpful if faith leaders also have this sort of mental health understanding. Oftentimes, this is like there's a sense of rigidity about rituals, like if I'm going to pray, I have to pray perfectly, otherwise my prayer wouldn't be accepted. So that's, at some point, it overlaps with OCD, and not always, but when it does overlap, it can be a manifestation of OCD. And if the OCD is in themes around blasphemous thoughts, compulsive religious rituals, and avoidance, then it could be very, very distressing for the patient. And they could be very worried that they're having all these blasphemous thoughts or sexual obsessive thoughts, and that's and then they feel guilty about it. And there is another case that I can talk about if we have time about this issue. But this is where it's helpful to treat with medications, therapy, and also counseling in general about psychoeducation. Religious passivity is something that in my psychiatric experience, this is something that a lot of people with depression can fall into. That thinking that praying to God would solve all problems and not taking appropriate actions. It is in some ways you could say could be a cognitive distortion or an misunderstanding of tawakkul, but it often is the sign of something deeper. It's not like you can tell this patient, no, that's not what tawakkul is, and you have to take your meds also. That's not going to necessarily help if you're just being so directive about it, because often it's a sign of some deeper conflict that's going on in their mind that's leading them to being stuck and to being so passive. So being aware of that. And then finally, another life-limiting form of spirituality, and I wouldn't even call it spirituality or religion, it's more religiously based or originating from some religious institution, any abuse, that can be extremely harmful for patients. And we've all heard these stories where clergy or faith leaders are abusive sexually, physically, but also in a more subtle way, people in our ordinary lives, like not even clergy, but people in our lives could, sometimes there are people who would throw something at you that this is religious teaching, you're not following it. And people can use the Quran or Hadith to manipulate you in a very subtle way. And often people don't realize that. So that's an abuse. And then there are more obvious and more extreme forms like extremism and cult-based spiritual practices. Spiritual problems and psychopathology. So based on that background, we could divide spiritual problems into 3 types: primary spiritual problems, secondary spiritual problems, and then complex spiritual problems. Primary spiritual problems are, like I mentioned, that we talked about earlier, life-limiting forms of spirituality that are the source of distress. Secondary spiritual problems, that's trickier. Now, that's more likely that you'll see this in this and complex spiritual problems in your clinic if you're a psychiatrist. It could be that the psychopathology is causing spiritual problems. I think we've all would have seen patients in psychiatry who are psychotic and have delusions that have a religious theme to it. And often, sometimes it's hard for the provider to distinguish whether someone is being hyper-religious or like is this just a part of their faith and they're being very much into their faith, or is this bordering to the point of psychosis? So that's something that we often see. Depression in itself can cause depression in itself can also cause yeah, I don't know where these arrows are coming from, but okay. So depression can also cause spiritual. Is someone annotating my presentation? Okay, depression can cause spiritual problems too. Like if you're depressed, you really don't want to get out of bed, you don't want to work, you don't want to pray, and that could, or you feel very hopeless. And that causes despair from towards Allah Ta'ala. And then complex spiritual problems are where religious and spiritual beliefs and practices, they could be both a cause and a result of psychopathology. So oftentimes when if something like, for instance, depression, if you're depressed, you become hopeless and you despair of God, you can go further away from God, then you can feel really guilty about that, and that, like, going away from God and feeling guilty and being hopeless could worsen your depression. So it could be a bi-directional thing. So I want to go back to, and I'm mindful of the time, I want to go back to the case that we started from, and a lot of you joined later, so I'll go over this case again, and then I want to share what I did, and then in the Q&A session, we could talk about what you would have done, what your questions are, what your thoughts are. And there is often no right answer in these situations, and often the important thing is to identify the question, and then once we have that question, we could brainstorm solutions. So this was a middle-aged Muslim patient. He presented to us my psychiatry clinic. He had profound depression, anxiety, PTSD, came for medication management. He was very reluctant to take medications and expressed distrust of healthcare providers. He had a lot of concerns. One of his concerns was that medications would be addictive and they could be harmful to him. The other concern was that he doesn't want to take anything that would change his personality, that would affect his relationship with God, that would, and then something that, and then he wasn't sure if he needs to take anything or just fix his problem himself, which is something that I see very commonly in patients. So how would you respond to him? And I'd given you this prompt at the beginning of the presentation to think about it. The way I'd approach this patient was that we had an extensive discussion, and we decided that if we found that if something is addictive, we talked about how psychiatric medications are not addictive except for certain medications, and that I would not prescribe him benzodiazepines, which could be potentially addictive. We would be doing SSRIs or mood stabilizers. And the patient, hearing that coming from a Muslim psychiatrist was very helpful, actually, because they could trust me more that I'm not going to prescribe them something haram because I know what haram is. So that actually worked out pretty well straight away in the beginning, and he was his concern about that was resolved. The next thing that he talked about was whether he should take medicines, whether he wants something that would change him. So that took a long time, and it required us to develop a strong therapeutic alliance. There was a lot of mistrust in the beginning, especially his trauma history had a role to play in that. And then we talked about it quite a while, and then eventually he, one day he was like, well, I just don't want to take meds. I think I can do this on my own. So I talked to him about how the Prophet had recommended medications for all for all illnesses. So why would you not take them for psychiatric illnesses? And then I told him this hadith tradition that I had read somewhere, that if you have, one time the Prophet, peace be upon him, asked for the Sahaba to prepare a dish which was made of barley and dates, I think, or oatmeal, I don't remember. And I don't know what the name of that dish is. It's something in Arabic. But the Prophet made this dish and asked the Sahaba to take this dish to people who were grieving from a loss. And he said that this would help them in their grief. So I gave that example, and then I said, well, you know, medications are derived from herbs, and herbs can be derived from herbs, and herbs are also created by Allah Ta'ala, and they're natural. So he was very convinced about meds after that point. And we continue to work on this. There continue to be times when he has more mistrust and less mistrust, but I think it was helpful for me to draw on those teachings, and I did discuss them with my clinic supervisor, and we found a way to do it in a very in a way that doesn't cross boundaries. And it was obviously in a setting where the patient wanted to talk about it and had questions about it. So how are we doing with time?
You have about 3 minutes to finish. Thank you for asking.
Okay, so let's just quickly talk about the second case that I had. This was a 30-year-old Muslim patient. He presented to the clinic and reported severe OCD with obsessive thoughts of a blasphemous nature. So it was one thing that he had these obsessive thoughts. The other thing was he felt horrible about them. He felt so horrible. He was like, these thoughts are so bad. I don't think God or the Prophet can ever forgive me for having these thoughts. And how would you respond to a situation like this? So in his case, his OCD was very severe. It was so severe that we had to give him antipsychotics in addition to SSRIs, which sometimes psychiatric providers would know if it's really severe OCD, at some point it starts overlapping with psychosis. It was very functionally impairing, so we definitely treated him with medications and therapy, which is obviously standard for OCD. But in that moment, I thought about what he said, and it reminded me of a hadith of the Prophet. And usually I don't share her hadith, so I was not sure if I should, but I went ahead and I did. And I told him of this hadith that the Prophet once a group of people came to the Prophet, and this is narrated in Sahih Muslim as far as I've seen, that once a group of people came to the Prophet and said, we have thoughts that are so enormous, that like doubts or negative thoughts that are so enormous that we couldn't even talk about them, and they're about faith. So the Prophet said, well, do you all have them? And they said, yes. And the Prophet said, well, that's a sign of pure faith. So the way that hadith is interpreted is that it either is a sign of pure faith, that you're having these thoughts, like it's okay that you're having these thoughts. That doesn't mean that your faith is bad or like you're not a good Muslim. And the other way it's interpreted is that you having these thoughts but not acting on them is also a sign of pure faith. When I said this to the patient, I wasn't sure if it's going to work. But I just shared it with him, but he was so surprised to hear it. This was a patient in Pakistan, and he was from a very low literacy background. And when I shared this with him, and he was just like surprised, and he like automatically relaxed, and like his expression changed. He sat back and he's like, wow, I didn't know that this was something that was there in the hadith. And obviously, and I couldn't follow up with him, and obviously I know that this was a difficult situation for the patient, and the disease is difficult to treat, and it's pretty relentless. But I think in a situation like this, at least it was very reassuring for him in that moment. And this is the sort of thing where it's helpful if your psychiatric provider knows a little bit about your spiritual background. And it's also helpful if your spiritual leader would know about or your spiritual scholars would know about psychiatry, so that they wouldn't just tell the patient, these are thoughts from shaitan, these are, you just need to stop thinking about them, you need to pray more, you need to sin less, because the concern there is that you're making them feel worse about something that is so like organic, like so neurobiological, that we know OCD has a neurobiological basis. So I think, so in terms of references, I did take a lot of my information from this lovely training that I had from University of Maryland, Bowling Green, and some other references, and I put some other references in the slides. So I will stop there, and then after the next presentation, we can have questions. So I'll stop sharing my screen.
Shuchi, you're on mute.
Thank you so very much. So beautifully presented. I was taking notes the entire time, but I'll save them till the end of the second presentation when it will be my chance to provide discussions. But for now, I would like to introduce our next presenter. And our next presenter, who I'm going to put on a spotlight as soon as she starts her video, Sarah Mohr. She has been an MSW, a social worker who's been a constant presence in our conferences for many, many years now. She said it was her 5th conference. And it's been a pleasure. Oh, 4th conference. And it's been a pleasure to, I think, meet her in all those 4 before this, and then meet her, all the 3 before this, and meet her virtually this time. She was born and raised in SF Bay Area. She has a passion for serving her community. She has a master's in social work and in religion and psychology from the Graduate Theological Union with a certificate in Islamic studies. I will start her presentation and let that be an introduction, and she will be spotlighted as her presentation plays.
اللهم صل على سيدنا محمد وعلى سيدنا محمد كما صليت على إبراهيم وعلى إبراهيم بركات سيدنا محمد وعلى سيدنا محمد بركات إبراهيم وعلى إبراهيم إنك حميد مجيد رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي آمين آمين بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. It is my joy and pleasure to be here today to present to you my research on liberation psychology and directive and non-directive approaches. I'd like to thank the Institute for Muslim Mental Health and the Muslim Mental Health Conference organizers, especially all volunteers, and to acknowledge as well that this research was a debt to Sabine Sheikh and Dr. Denise Berta, who contributed to some of the critical thinking involved in developing the work. So with that said, without further ado, let me share my screen with you. So my talk today is on liberation psychology and directive and non-directive approaches. My name is Sarah Huxtable Mohr. I work at Larkin Security Services in San Francisco. So in the interest of time, I'm going to go through this very quickly. So liberation psychology is something that is very talked about right now, especially with the Second American Revolution happening, all the work that's going on for liberation in the world. It's more and more being talked about, all the work in decolonial psychology being done. But the work that we're seeing now in liberation psychology really goes back to the 1960s liberation theology. So there's some debate on the origins of liberation theology. One theory is as a result of Vatican II and Maryland and South America, liberation theology was developed in South America and Central America, and then spread from there out into the rest of the world. A second theory is that there are convergent streams of thought in response to the well-tension of the 1960s that gave rise to feminist liberation theology, Black liberation theology, Muslim liberation theology, and other liberation theologies. The basic premise of liberation theology is that historically theology was done to support power and to support the status quo in the interest of the oppressor. And the goal of liberation theology was to do theology in the interest of the oppressed, not the oppressor. So it was a Christian theology based on Catholicism originally in most of its iterations. And the Christology, instead of Jesus in the sky, was finding Jesus in your in the poor, and a soteriology of salvific action of engagement with oppression, and not just sacraments or communion, but actual lived engagement. An eschatology of the end times being ongoing revelation of God's work and love and history towards a just reality, not the rapture and Jesus descending from the sky to change the world in the twinkling of an eye. So those kinds of concepts were the basic framework of liberation theology, and it was centered around a concept called the preferential option for the poor, which first entered the literature of the Catholic Church in those words at Latin American Conference of Bishops at Puebla in 1975. That's when it entered the literature, how it entered the vernacular of the liberation theology movement all through Central and South America long before that. And Dr. Frida Sack, who is the most famous Muslim liberation theologian, who I'm sure many of you know, critical in the work for apartheid, to abolish apartheid in South Africa. As many of you know, I'm sure the Muslim voice and Call to Islam were critical in the work of abolishing apartheid, and Dr. Frida Sack works extensively with the concept of the preferential option for the poor and authentic engagement with the other. And it's oriented primarily around the concept of a God of justice. So rather than a God of judgment or power or authority, hierarchy, it was based on the concept of a God who was a God of justice. So liberation psychology, unlike liberation theology, is not debated about having emerged from one stream. There's pretty wide consensus that liberation psychology emerged in simultaneous places around the world in response to the liberation theology movements that had diffused around the planet. So currently, as a result of scholarship in the 1990s, the primary person who most people think of is Ignacio Martin Barrow. Martin Barrow was a Jesuit priest in El Salvador who was murdered by a U.S. Stream death squad tragically in 1989, as well as his work challenging the oppression of people in El Salvador. And Martin Barrow traced his work back to liberation theology in Latin America due to his connection to the Catholic Church. So he was a Jesuit. Martin Barrow's work, Rays on Liberation Psychology, were published in English in the early 90s, and Noam Chomsky actually presented at the APA convention in the early 90s on Martin Barrow's work, and it's an ongoing conversation about liberation psychology. But it was not only that Martin Barrow did this work. Liberation psychology also emerged in Ireland with Geraldine Wani, Starhawk, the Wiccan priestess in the United States, worked extensively with the concept of liberation psychology. Eduardo Duran worked with the concept of liberation psychology in the Native American community. The concepts of post-colonial psychology are all oriented around liberation psychology. Fanon is quoted by many to be a liberation psychologist. Liberation psychology is oriented universally around some basic premises, the primary one being that psychology should have an explicit goal of establishing justice, social justice, environmental justice, gender justice, racial justice, and not maintaining the status quo. So as part of the goal of doing psychology with the goal of justice, you can see threads that run through all the different liberation psychology thinkers. Some of them are critique of a trans-historical and ahistorical perspective, universalizing and generalizing about people that regard to culture, scientism positive, it can't be tested, it's not real, reproduction of hierarchy and models of dominance endemic to patriarchy, white supremacy, classism, and colonialism, individualism, and the individual person can be taken out of the social environment and treated without the context that they lived in. Famous work is being done in Palestine around this, and it's a very intuitive thought. How do you treat a Palestinian who's traumatized by the violence of the Israeli government? Taking them out of the social context and thinking you can give them treatment for depression, in the context of what they're going through socially. There's a concept that you simply cannot take the person out of the social environment. And one of the things that is important to mention is that in third world countries and in the Southern Hemisphere and the Global South, liberation psychology is already widespread and has been used in South Africa. Silat has been used in Bangladesh, and Rahman has been used in Palestine, Makawi. So is a conversation that's going on in the Muslim world in the Global South fairly extensively. So at least as far as I can tell from the literature, I've never having been there, I don't know, but it seems like in the literature it's very widespread. And obviously that makes sense because taking a Eurocentric paradigm and putting it in a colonial, post-colonial environment is obviously not an intuitive fit for most people. So another thing that was criticized was the concept of hedonism as the innate nature of all beings. People universally seeking pleasure and avoiding pain as their primary motivations in life. So this is based on Freud, Marcuse, the fact that Freud wrote about the concept that people seek pleasure and avoid pain, and the only thing that kind of limits our endless pleasure seeking is the boundaries of other people's endless pleasure seeking. And Martin Brown said, and many other people have said, you simply cannot ascribe all human nature to seeking pleasure. The self-sacrifice of a El Salvadorian peasant in the interest of revolution, or the self-sacrifice of one individual for another individual, this is not purely about pleasure. That people have altruistic motives, people have spiritual motives, and people have higher motives in life beyond just simply, base human desires. And a lot of work on this is that people have altruistic motives, people have spiritual motives, and people have higher motives in life beyond just simply, base human desires. And a lot of work on this is obviously echoes works that's being done in the field of Islamic psychology around the construction of the self in historical Islamic psychology, and the fact that this framework prioritizes the Eurocentric view of the human person, scientific, materialistic, epistemic, that disregards a lot of truths that are fairly obvious to a lot of people who don't follow that worldview. So, moving on specifically more to my research, collectivism versus individualism is something that I began to focus on in my work on liberation psychology. And by the way, I have a paper on liberation psychology, which you can read more about this. So if you have any questions, you can text me on the WOV app. Collectivism versus individualism was something that I focused in on my work on individualism. Collectivism versus individualism. Collectivism versus individualism is something that I focused on my work because there is kind of a popular wisdom and to some extent truth that Muslim majority communities and countries emphasize collectivism over individualism more than Western European and white North American culture. This has led to an emphasis on directive approaches in the literature. And I'm sure many of you have heard of it. I've asked this question before, and a lot of hands go up. Have you heard that Muslims respond well to directive approaches? There's quite a bit in the literature that Muslims report they prefer directive approaches. However, I had an interest in questioning this for a variety of reasons. And basically, it started out with a question about cultural humility and cultural competency. So cultural competency is kind of an old model from multiculturalism to cultural competency, which is progress from total insensitivity and help providers avoid some blunders. It was based on the belief that you could understand cultures in ways that would apply to members of all groups and had a huge danger of stereotyping. Turbo and Maria Garcia came up with the model of cultural humility, self-reflection, and lifelong learning, which involved curiosity and a genuine engagement with people as they are, and being committed to gaining knowledge of other cultures, but understanding intersectionality better than cultural competence tended towards. So this question about collectivism versus individualism, cultural humility, led to a question about directive approaches. So like I said, they're discussed in literature on Muslim mental health is more appropriate for Muslims than other people due to collectivistic natures of Muslims. There's a danger of culturally competent people taking this approach without reflecting on individual needs. So I thought it would be fruitful to discuss potential other avenues of research and investigation. Directive approaches, according to most liberation psychology thinkers, reinforce hierarchy and models of dominance. There's a danger that directive approaches recreate repression in the clinical environment in a way that mirrors and supports cultural repression. And that therefore with colonized people, it's actually not necessarily the most productive thing to do to direct people to kind of fix their individual problems in an individualistic kind of trans-historical ahistorical framework, because obviously if there's a social justice problem, understanding that context is more empowering than than just isolating the individual. And obviously, so directive approaches are increasingly dangerous for people who've been silenced already socially, such as women, LGBTQ individuals, and African Americans, or people of color who have been historically increasingly marginalized. And the conversation about elevating people's voices, well, if the entire conversation is about elevating people's voices, being directive in therapy is not necessarily really even honoring that dialogue. So my research went toward non-directive approaches, and this is something that Martin Barrow talks about extensively. Paul Freire was a Brazilian educator, and he emphasized dialectical approaches, dialogue, as a way to raise consciousness and engage oppression as an educational approach. So not banking education, where the teacher puts in the information and the student spits it out on test time, but a dialogue, a raising of consciousness. Other non-directive approaches are client-centered approaches such as unconditional positive regard, and forces and oppressions on individualism. Societal oppression has the potential to produce depression, anxiety, and psychosis, as well as a variety of other psychological disorders, and that's widely reported in the literature. Martin Barrow, Watkins, and Schulman, but also Fanon talks extensively about this in his work on psychology in his work. So at this point, I really want to again acknowledge Sabine Sheikh and Dr. Nisberta for their thinking on this. But one of the questions we asked was, if you're taking non-directive approaches, what if you apply the concept that collectivism was super central to Muslim mental health and use group therapy approaches instead of individualistic approaches, like one person in a room with one person, is atomized individual approaches, try and work from a group approach. So we talked about the fact that there's directive group therapy, which can utilize interventions that could draw from traditional Islamic contexts. This is Muslim mimbars or halqas or iftars, and the importance of cultural alignment between group leaders and participants. Also, non-directive group therapy that utilizes collective tendencies such as conscientization, consciousness raising, dialogue, and honors the possibility for emergent knowledge and generative themes, which could really allow people to tap into their ability to relate to other people. And this has been widely documented. Group approaches have been widely documented as highly effective among people who have experienced a lot of stigma, because being in a group environment where you're talking about your mental health challenges with other people who are experiencing the same thing can be very normalizing. And we all know the conversation in Muslim mental health is very oriented around stigma, as it is in all mental health, but particularly in Muslim mental health. So there is quite a bit of research, if you start looking, about the importance of group therapy for overcoming stigma. So the key takeaway is to find new ways of being in the world. Innovative approaches hold possibilities and opportunities for pioneering new forms of practice. If we're going to figure out how to live in a better world, we're going to figure out how to actually make liberation and revolution happen, we need to think outside the box. We need to create new paradigms. The old paradigms are not working. We don't have a new paradigm. We're in a totally new world than we've ever been in before, and we need to be pioneers. That's Fanon's words. We need to be pioneers. We need to create a new human being. We need to figure out who we are and who we can be and what the possibilities are for humanity. Further research is obviously needed, including the impact of societal oppression and psychological disorders. It's important to raise awareness due to both individual variation and multiple outgroup memberships that assuming Muslims respond better to directive approaches could lead to poor clinical outcomes. Engaging in psychology with the goal of creating a more just world requires supporting people's consciousness. Simple thought. If you want to create justice, support people's consciousness, because the power of the people is going to transform the world. So to nurse that light, to fan that flame is a possibility for psychologists, for Muslim mental health workers. Clinical approaches that support empowerment, self-expression, agency are particularly appropriate for women and LGBT. And finally, group therapy as a form of intervention is under research and developed as a way to incorporate cultural emphasis on the group due to collectivism and holds promise that needs to be explored. Thank you again to Sabine Sheikh and Dr. Nisberta, the Institute of Muslim Mental Health, and the organizers of the Muslim Mental Health Conference, especially Dr. Farah Abbasi, Dr. Hamad Hamid, and Mary Fadasi, the Center for Islamic Studies and Graduate Theological Union, especially Dr. Munir Jua, and finally, Black Institute Youth Services for supporting this work. I really appreciate all of you for coming to my talk. Thank you for taking the time to listen to me. Be well, stay healthy in the midst of all of the chaos, and hope to see you in other talks soon. Take care.
Thank you so much, Sarah. That was a great presentation. Thank you.
Mashallah, thank you, Dr. Abbasi. Are we going to go into a question and answer period at this point?
Yes, well, I want to do a quick, if you will allow me, 2 to 3 minute summary of each of the presentations as your discussant, and then we can move on to the Q&A session. Although I feel humbled to be able to do this, seeing that there's an August gathering present in the attendees, but yet I will take a minute and do that. So first for you, Hira, thank you so much for sharing the OCD Bridging on Psychosis case. That's something that we share and see the strong religious components in our practices day in and day out. And you're right, they're one of the hardest to treat. I think few of the take-home points, which I thought were incredibly important, is when you distinguished two things that one must be aware of: the spiritual over-inclusivism versus the spiritual exclusivism, and that both can be dangerous. I think it was wonderful that you talked about spiritual milestones, just as anybody else would talk about other developmental milestones in a person's life. That's something we usually are not as sensitive to, even with psychiatrists who are trained to be culturally competent. I loved how you used the concept of spirituality, both in the psychodynamic forms of psychotherapy and within the CBT. The fact that you talked about the transference and countertransference having a strong religious undertone, and you were talking about how object relations could be highly affected by a person's own spiritual health. I also loved how you talked about spiritual cognitions and talked about both spiritual cognitive distortions and using spiritual cognitive reframes. When you talked about using a concept that's valid to someone's life to make sure that it changes how they think. Thank you so much for sharing. For you, Sarah, I can't think of another time in history where it has been more important to talk about liberation psychology than this time, as the list of the number of minorities who will consider themselves oppressed is getting increasingly larger and longer, not just here, but throughout the world. I very well taken your point on not ever letting directive approaches come in the way of shared decision making, and to be looking at new and innovative ways on how we can make this happen, particularly using group therapy as an approach. So with that, I would like to open the floor to anybody who has questions. I saw that in the chat, there's already, I think there's the name of the dish, talbina, is that how you say it?
Yeah, I thought that's what it was, but I wasn't sure because my Arabic isn't that great. So I was like, I haven't looked the name up, but yeah.
And I know some people, I think, missed a little bit of what Sarah was saying. So if you did have any questions about any part of her presentation, this would be a time. Please use the raise hand feature in your little palette on the right-hand side, and I can unmute you. You can also type and send me the questions in the chat.
So hi, everybody.
Hi.
Go ahead. Assalamu alaikum, everybody. Just Saira Qureshi here in Massachusetts. I'm really thankful for this conference, and Dr. Abbasi, thank you for organizing. Everybody else who did this is an amazing opportunity to learn and be in the company of colleagues and everybody working on different client cases as well as sharing their knowledge and models. Quick question for Sarah. Working with children and adolescents, how would you say that your directive or non-directive strategies could be a little bit strategically more modified? Because I imagine handling spiritual questions for children and adolescents, maybe 10 years upwards, could be possible conflict reasons with parents. I primarily work with children and adolescents, and I see that a lot in both Muslim and non-Muslim families, that if children are not as inclined, especially middle school and high school children and adolescents, towards religious, moderate even knowledge and discussion, that their parents encourage them to stay on track with basic organized religious activities, or just in general follow the ethics of everyday practices, whether it is dressing or eating or listening to the kind of music that they listen, etc. And then that can cause rebellion or anxiety and depression in youth, as well as frustration in parents.
Thanks for your question, Sister Saya. Assalamualaikum warahmatullahi wabarakatuh. I think, you know, my work on non-directive approaches was actually, I think, very connected to my work as a school counselor, where I was working with play therapy. And the concept that non-directive approaches are trauma-informed, and in terms of, you're talking about working with children, you know, play therapy is, as I'm sure you well know, one of the most evidence-based practices for interventions with children. The concept that you're following the child is leading with their behavior, that you are attending, and the concept that just really listening and attending, and the interaction of just really genuinely attending to children is a critical intervention for trauma. You know, if you look at, especially for Muslim children, the prevalence of bullying and the level of silencing and kind of the fact that that there's the fact that there is the problems that they have societally in the greater social context. You know, the concept of play therapy where the child is leading is actually probably really rooted in where this kind of work came from for me. I don't know if that answers your question. My work is actually with transitional age youth, and not so much a play therapy modality, but I think even with youth, the concept of just really being present is critical. And in my work with transitional age youth, I do community meetings and circles and restorative justice practices that that prioritize just genuinely being present and being in community in ways that are trauma-informed and healing for my clients. So I don't know if that helps.
I have a question for Hira. So Hira, excellent presentation. I've never really, I've personally experienced it with my clientele, where this religious obsessiveness can be part of OCD. I was very glad that you touched on it. And similarly, so I have a case recently that I'm dealing with where during Ramadan, where the young student started having these religious spiritual experiences that he thought was part of his ibadah, and actually he was having his first psychotic breakdown. So I do agree that OCD is a shade away from psychosis, and antipsychotics do have a role when the delusions or obsessions get to that point. So I'm really glad you brought that point up.
Thank you. Yeah. I just want to add that I think the other thing about psychosis is that I have found in my experience, because I wear a hijab, that sometimes I have, my appearance feeds into people's delusions. So when I was working at the state hospital, there was a patient in the forensic ward who had some problem. I just went to talk to them. It was overnight, and he was Muslim, and he looked at me, and then he was just like, oh, you're here to save me and we're going to conquer this hospital together. And he just got so delusional about that. He would write me letters and send those letters to the attending. And I was so embarrassed. I was like, oh my God, what did I do? And then people would come and approach me, and like I had this really sweet psychotic patient who would come and tell me, look, I'm not, I'm Krishna. And I'm like, oh, okay. And then he's like, yeah. And then I was like, I don't know much about Krishna. So he's like, but that's okay. I don't know much about Jesus Christ either. So what he had thought was that I was Hindu. I don't know why, but maybe because of my Asian appearance. But it's interesting that this could happen even in psychosis, that you could like expand on someone. You could like have religion, like based on your religious context where you grew up, you could have delusions based on that. So that's
in this similar vein. Right now, I think we are also experiencing a lot of paranoid delusions in religious communities.
Yeah, and for instance, I had this one patient who would look at me and he was really psychotic, and he looked at me and he's like, well, I hate Muslim people. And then he looked at the medical student next to me, and he was African American. He's like, I hate white people too. And then he kept saying that and kept saying that. And he walked away, and then a few days later, after getting medications, he was just quiet and the most pleasant person. So when it comes from someone who's psychotic, I don't get offended. But there are times when it also comes from people who are not psychotic, and then it's harder. Yeah.
Good presentation.
Thank you.
Since I don't have any questions in the box, I have one for you. So what advice do you give to your fellow residents who are non-Muslim providers, but who do meet with Muslim patients? What advice do you usually give them if you were to give them, I don't know, like 5 pointers on what to do and what not to do?
That's a good question. I think that my fellow psychiatry residents also don't know how to deal with Christian patients, because so let alone Muslim, I find that there is a huge bridge that needs to be crossed, especially in the South, where people have strong faith values, and providers, psychiatry residents and faculty often tend to be not that spiritually minded, or if they are, they don't want to talk about it in the US. So we decided to do this symposium, where I think the first thing that I tell them is that if you find that you don't know about a situation and you're having these questions and you feel that you're totally not in a place to help the person at all, and you're afraid that you'll say something to harm them, then the least you can do is have a chaplain consult, because that's an option that's available in the hospital for a lot of in the hospital or in the clinics. And I have found that chaplains, unlike psychiatric providers, chaplains from all chaplains are so well trained in all the different faiths that they could just sit and walk you through some of the questions that you have. So we've had regular chaplain consultations, especially when we are trying to distinguish between hyper-religiosity and psychosis, especially if we don't know that much about that person's faith. So I would recommend to non-Muslim providers to do the same if there is a Muslim patient. The other thing would be that I tell people is that that I've experienced is that someone has treated 1 or 2 Muslim patients, or they've had Muslim friends, and they think that they know quite a bit about Islam. And actually, unfortunately, that's true for Muslim providers too, that we just assume a lot, that we know a lot. So what I remind them is cultural humility, that you can never really be competent in someone else's culture. What you could hope to aspire for is cultural humility. And if you ask questions the right way, it would be, you could like be very receptive to learning from your patient. And the third thing that I would say is there are spiritual assessment checklists that I didn't include in my slide, but there are like scales that you could use, and I know they must have been covered in other presentations, but those are very helpful to take a spiritual history. So that's something that our program decided to educate residents about. And I think, Dr. Abbasi, you came to Duke, I think, a while back, right? I was on night float, so I didn't attend your grand rounds, but, and I was really sad about it. But it was really nice to have someone come and talk about Muslim mental health at Duke. And I see that two people have raised their hands also.
Yes, Masume would like to go next.
Yeah, thanks. I put my question in the chat, but it seems like no one ever sees it when I do that. Maybe because I'm using the web application. But basically, about using non-directive or directive approaches with Muslim clients or with Black clients, or because we receive this like multicultural competence kind of, like the research shows that certain ethnic groups, racial ethnic groups or cultural groups prefer directive approaches because it's more compatible with their culture and the way their families work. So as a marriage and family therapist intern working in settings that are mostly, where I was mostly seeing Afro-Latino families, I had to give up some of my post-constructionist like approaches because it would have been imposing my agenda on them and imposing my historical context on them. They wanted me to relate to them through a directive approach, and it was most helpful to them. So I'm just wondering if there's room in that dialogue to not necessarily call a directive approach an oppressive approach, or what were your feelings on that?
I think it's really a point that's well taken, that that a lot of people do. A lot of Muslim people engaging in mental health services do report that they prefer a directive approach. And my intention is not to kind of challenge the research on that per se, or to impose my filter on other people's experience. That's not the intention. And I have a paper coming out, inshallah, on this topic. And one of the things I talk about is, the concept of using a non-directive approach for Muslim mental health runs the danger, if you're saying it's decolonial, of imposing a colonial Eurocentric paradigm of locating freedom and individual choice on a construct that is claiming to be decolonial. So it's kind of like it's a contradiction in terms to some extent. However, that's not the intention of what I'm trying to say. I understand the critique, and it's not actually the intention. The intention is of this research is to open up the dialogue and just continue to invite reflection on what are the possibilities for using dialogue and consciousness raising as a therapeutic modality. And the starting point of what is the issue about directive approaches, is the starting place for reflection, and the concept of using non-directive approaches as not an ending place. And as you saw in my slides, perhaps, I'm not sure if you saw this in my slides, but one of the questions that we did ask was, are there directive approaches that are oriented towards the group that are actually really the ideal intervention for Muslims, like directive approaches like that use Islamic context and use kind of indigenous modalities of interaction in a directive way that would actually be the ideal outcome for therapeutic intervention for Muslims, or for marginalized communities of color, women, or other groups who've been oppressed and disenfranchised through historical oppression. So the intention is not just to say, oh, be non-directive because we're trying to be decolonial. That's not at all the intention. The intention is, and I understand the problem with it, and I understand the importance of directive approaches. That's not the intention. The intention is just to open up dialogue and reflection.
Thanks so much.
Next, we have Margaret Keeler here from NAMI Lansing, and I believe she has a comment with regard to liberation psychology. Margaret, you have about 3 to 4 minutes before we end the session.
Well, thank you so much. I really just tuned in right at the end, but I really appreciate that the discussion on liberation theology and how that interacts with liberation psychology. And as an organization, NAMI is trying to connect with communities of color and see how we might be able to reach out in a positive way. And that really resonated with me about the group dynamics and the using that as a theoretical background for guiding us in how we try to gently and appropriately, along with other members of our board, to address specific concerns in our community. So I've just learned a lot right from that, from the beginning. So I appreciate that. Thank you.
Shuchi, I would just like to add one quick comment. Thank you for joining, actually. It's great to have you here. But just a quick comment to your question that for a non-Muslim, how to deal with a Muslim patient. My answer to that is, and that's what my Duke presentation was about, is it's like if I ask you that, how do you respect other people's mother? Right? We all know that. So it's about addressing and respecting the human dignity and human experience of each one of our patients. And if we tap into that, and if we are tuned into that, we really don't, there's no way that all of us would know everything about everything else. We can learn a lot from books that this religion says this, or like you said, that even being a Muslim, I can't claim that I know everything. But the point is not knowing everything. Point is, how do you hold your patients through their journey and what you can do to walk with them. So holding their hands and they allowing you to hold their hands. So they walk you through everything. You don't have to know anything. It's just the empathy. The relationship once created, they will walk you through everything. To having that humbleness and humility.
Thank you so much. That adds on to what Hira also very well put. We are in the last 2 minutes of our session, so I'm going to give both our presenters 45 seconds to a minute each to give their last closing thoughts or words of wisdom. Sarah, do you want to go first?
Thanks, Dr. Shuchi, for moderating, and to the organizers of the Muslim Mental Health Conference. I think I appreciate being included and allowed to present my research, and look forward to, inshallah, seeing you all in person in the future, inshallah. Thank you so much for including me.
Thank you so much for coming and being here and enlightening all of us. I think I'm going to go home and read some papers on liberation psychology at the end of this. Hira?
Thank you, everyone. It was great having this discussion, and it's been a great thing. I've had a great time attending this conference. This is my first time attending and presenting in this conference, so great to see you all, and hopefully I'll meet you all in person next time. Thank you.
Thank you so much. And if you keep bringing such amazing presentations, we would recommend you come back every year.
Thank you.
Thank you all for joining in. This will bring us to the closing of our session. Thank you, the audience, for participating throughout the session. Thank you for the presenters, adding so much to our knowledge. And thank you for Dr. Abbasi, for being here whenever needed and providing her immense knowledge with things we all can learn from. So thank you all. Assalamu alaikum, and we'll see you in the next session.
Thank you.